Well, value in healthcare is the outcomes achieved relative to the money spent. Accordingly, if the outcomes that matter to patients are not improved, value is zero. There's no clinical benefit to the patient. However, today there is substantial variation in terms of process and outcomes between hospitals, because everything is heavily focused on process, not outcomes. For instance, if you compare the differences in outcomes between hospitals in Europe, you see that in Belgium, the mortality rate for rectal cancer is 7 times higher for some hospitals compared to other hospitals with exactly the same case mix of patients. So the question is not really about accessing to care, but accessing to the equal outcomes for care in every possible setting within a country or the European Union. So first, you need to focus on outcomes that matter to patients. So outcomes or end result of care that patients see as really important in their daily life. The idea is really to focus on what patient thinks important in their daily life. So we measure quality of life, we measure functional recovery with calibrated instruments that deliver a scorecard, and then you measure the score before, throughout the treatment, and after treatment. And the difference between the score after and before provides you with the added value or the clinical benefit for the patient in his or her daily life. For cataracts, for instance, there is an instrument that measures the visual quality in daily life for patients throughout 9 questions. Can I read a newspaper on a scale from 1 to 4? Can I read the subtitle on TV from 1 to 4? Can I recognize the faces of people I meet every day from 1 to 4? And you come up with a score that you measure before and after surgery, and the difference tells you what is the added value to the patient. Now, the clear focus on our work is how to implement it. The good news is that value-based healthcare works, and we have seen the results in many different cases across different countries. Bad news is that the implementation of VBHC is not straightforward. So for that, we adopted empirical approach. We interviewed 200 European experts who are already working on the implementation. We also selected 30 pioneering sites that we visited in order to detect what are the best tools and approaches to make a successful implementation. Now, we came up with a matrix tool for this implementation that combines 5 dimensions: recording outcomes, comparing outcomes, rewarding outcomes, improving outcomes, and also partnering. The idea of this tool is to create a consistent and dynamic approach for this implementation. Of course, it's important not only for EIT, but for the best-in-class innovators across Europe, because with this approach you can detect what are the innovations that are associated or that deliver the highest possible outcomes. And this detection enables to accelerate the adoption of those innovations. 17 years is the average length to adopt an innovation from bench to bedside. 17 years. And outcome measurement can dramatically shorten this adoption in order to provide those innovations more rapidly to patients and health systems.